critical appraisal of the SIBO hypothesis and breath testing, a clinical practice update endorsed by the European Society of Neurogastroenterology and Motility and the American Neurogastroenterology and Motility Society. There is compelling evidence that microbe-host interactions in the intestinal tract underlie many human disorders, including disorders of gut-brain interactions, previously termed functional bowel disorders, such as irritable bowel syndrome or IBS. Small intestinal bacterial overgrowth, SIBO, has been recognized for over a century in patients with predisposing conditions causing intestinal stasis, such as surgical alteration of the small bowel or chronic diseases, including scleroderma, and is associated with diarrhea and signs of malabsorption. Over 20 years ago, it was hypothesized that increased numbers of small intestinal bacteria might also account for symptoms in the absence of malabsorption in IBS and related disorders. This SIBO-IBS hypothesis stimulated significant research and helped focus the profession's attention on the importance of microbe-host interactions as a potential pathophysiological mechanism in IBS. However, after 2 decades, this hypothesis remains unproven. Moreover, it has led to serious unintended consequences, namely the widespread use of unreliable and unvalidated breath tests as a diagnostic test for SIBO, and the resultant injudicious use of antibiotics. In this review, we examine why the SIBO hypothesis remains unproven and, given the unintended consequences, discuss why it is time to reject this hypothesis and its reliance on breath testing. We also examine recent IBS studies of bacterial communities in the GI tract, their compositions and functions, and their interactions with the host. While these studies provide important insights to guide future research, they highlight the need for further mechanistic studies of microbe-host interactions in IBS patients before we can understand their possible role in diagnosis and treatment of patients with IBS and related disorders. All right, let's talk about what this means. This means that small intestinal bacterial overgrowth, SIBO, is a real diagnosis. It's been around for over 100 years, and it occurs in people who have underlying chronic disorders like scleroderma, which basically hardens the tissues, so the tissues don't move, so there's stagnation, or small intestinal resection, meaning they cut out a chunk of the small intestine, and that impacts the motility. So that's what we know, 100%. That is the diagnosis of SIBO. And then what happened is the idea was floated out there that maybe SIBO is more ubiquitous. Maybe people with IBS really have SIBO. And then a breath test came along and a drug treatment came along. And I want to point out that both the two underlying chronic problems that predispose real SIBO are end up with malabsorption issues and diarrhea, right? Which is why you prescribe antibiotics. You don't prescribe antibiotics for constipation. So this hypothesis came out and became popular. And listen, people want answers. They don't feel good, so they want answers. And so it became a really big thing. And now what the gastroenterologists are saying in 3 separate countries or areas, Europe, Canada, and in the United States, is that this is not a real diagnosis. This breath test is highly inaccurate, and people are being over-treated with antibiotics based on this diagnosis, and really we have to rethink it. And I couldn't agree more. I could not agree more. And that's the reason I started to actually talk about this stuff in the first place, was because I saw this use of antibiotics, course after course after course, for these poor people who probably end up in the long run worse off than when they started. And that's when I usually see them, after they've had numerous courses of Xifaxan, rifaximin, or metronidazole, or erythromycin. So let's change the narrative on this and dial ourselves back a little bit and reevaluate the use of these breath tests and the accuracy of these breath tests, and also the use of repeated antibiotic treatments for people with this diagnosis. Now, the caveat is, if you have diarrhea, IBS-D, and you test positive for SIBO, and it's not an accurate reading that you get because it's not an accurate test, and you get better when you take Xifaxan or rifaximin, you are treating IBS-D, which is one of the indications, the labeled indications for using Xifaxan or rifaximin. That's why you got better. I hope this shed some light for all of us on the progress and being aware of the process that science and medicine have for actually establishing a diagnosis, and the difference between a hypothesis and an actually accepted medical diagnosis.